Hello, welcome to ExtraMed's Patient Flow webinar. We have three presenters for you today. Martin Jagdeo, the Deputy Operations Director for Luton and Dunstable. Myself, Susan Say, the Managing Director for ExtraMed, and Sam Hall, who is the Product Manager for ExtraMed. We're going to be covering the following areas today: the strategic and operational goals that ExtraMed as software supports, a case study which will be presented by Martin, and he will take you through his journey how Luton and Dunstable improved their A&E target performance. Sam will then present and share a case study with you completed by Derby Royal and address how they actually tackled winter pressures using the ExtraMed patient flow solution. I'll also give you an overview around ExtraMed, who we are and what our software solution delivers. We'll also talk about implementing patient flow and what we've learned during this journey. And we will summarise at the end with the content of what we've actually covered from the webinar. In addition, we'll also be sharing with you what strategic and operational goals the ExtraMed patient flow solution supports. And I'm now going to pass you over to Martin Jagdeo from Luton and Dunstable.
Hi, good afternoon. My name is Martin Jagdeo. I'm Deputy Director of Operations at Luton and Dunstable Hospital. Today I'm speaking about improving A&E target performance and our case study here at Luton and Dunstable Hospital. Basically a population of about 315,000, 93,000 inpatients and day cases at Luton and Dunstable Hospital, 375,000 outpatients. At this hospital, 5,200 babies are born every year, and we've got approximately 670 beds plus 80 beds for daytime places only. Our budget's around 310 million, and we've got close to 4,000 staff working for us. We've got 12 theatres and 2 ring fence for maternity theatres. That's a bit of background of the organization. Our emergency department, last year we saw 144,636 patients. The breakdown for that was 101,060 patients went directly into our A&E department. 43,576 went to our on-site urgent GP service, streamed from the A&E department. So footfall, 144,636 patients attended the site. We've got approximately 8,500 attendance per month, and a quarter of that, 25% of that, is pediatrics, and that's just an average of about 2,000 a month. Our acuity, just like any other A&E department, is split between majors, resus, pediatrics, minor injuries, and resus. And sort of a percentage breakdown we've got is like 43%, the bulk of the work comes through majors. Again, 25%, a quarter, goes through pediatrics, 23% minor injuries, and 9% very, very sick people go through resus, including the traumas and things like that. Looking at our urgent GP attendances, our A&E attendances, and the whole site attendances, color-coded against that. You can see from April 2013 to April 2017, and we're working on the graph to continue into 2018. Is you can see the green line showing the whole site attendances, and you can see the ups and downs around that, and increasing sharply in February 2016 and sort of steadying a little bit of a dip in 2016 and then sort of steadying. So it's really a steady number increasing. And the same for urgent GP numbers, fairly steady and increasing. And the whole site attendances are fairly steady, in line with national numbers according to increases in the number of patients using accident and emergency. We showed changing demographics. So, for example, this is a very interesting one. If we look at from 2013 to 2016, and we look at ambulance attendances, we look at that increase. You can see the graph increasing for ambulance attendances, the graph increasing for people under 15, the graph increasing less for over 75s, a little bit less for over 80s, and yes, for overnight attendances. As a former clinician working on the shop floor, I can tell you the number of ambulances and patients coming in overnight. Our nights have become very, very busy. And yeah, we've had to increase our numbers of nurses and the number of doctors working on night shifts in line with the trend of these numbers going up over the years, that is. Our journey in 2010, we were the worst performing trust in the east of England. And by 2012, we had a turnaround. We had an intervention, and we turned around, and we consistently delivering on the 4-hour standard. By 2012, February 2018, we were the number one trust in England for the A&E 4-hour target. Dramatic turnaround. Lots of intervention in between in those years. Demographics, a rising number of elderly, and as I said, the rising number of patients arriving at night. I want to add to that as well. I said the rising number of pediatrics coming through, and working with that gap from social services and the services that are available to support frail elderly in the community. Yes, patients having complex needs and living longer, and of course, just like any other organization, monitoring our estate and not just like any other organization, I should say, is the fact that our estate is we've had issues with resilience and capacity. The size of it, we've grown, but it's our estate is very limited in terms of space. Yes, just like any other organization, this one should be right now. Workforce. We have challenges in overseas in recruitment, in recruiting doctors, and recruiting nurses, and we've also gone overseas to do the same. Just like other organizations in the NHS, we face the same challenges. Being just on the outskirts. I mean, if you know the hospital and the geography, we're basically just off the M1, and so our workforce are easily pulled into London and London waiting, and the advantages in terms of salary and with London waiting does give people the pull, and obviously the big city life does give people a pull in that direction, particularly younger workforce. So we are challenged by that. And yes, financial rising costs above tariff, uncertainty around sustainability nationally. All these are some of our key challenges that we face, not unlike any other organization in the NHS, I must say. More key challenges including overstretched primary care. Yes, the public expectation of a service that must be quality with excellent customer relations in a in an environment where it must be delivered on time, and those challenges come back to us with of course having competing priorities and many priorities in the organization, as well as the 4-hour target, and yes, and the lack of a 7-day service in the community, and particularly we see this around the challenges of getting people out of hospital on the weekends. What has changed? That's the question you're all probably asking in your head from 2010 to 2018. What has changed that allowed us to increase our performance, to improve our performance, and to get to being number one? Yes, so we had a change. We had a change between 2010 and 2012 in a new leadership. We had a new chief exec who've come into the organization and who worked with the exec team to really understand what the issues is around it, achieving a safe service at the front door. Basically, our new chief exec really got together with everybody across the organization, made us feel as part of the whole organization, and we got whole hospital ownership because we saw the A&E 4-hour target as a safety mechanism, not just a target. We all work with the theme that overcrowding kills. College of Emergency Medicine research has proven you have an overcrowded A&E department, people will make mistakes, things will happen, and yes, some people will die. Investment in space and people took place. We more or less doubled the nursing team, increased the consultants. We started off with, I remember working in the department many years ago, and we had 3 consultants. We now have 10 going on to 12. And yes, we invested real-time information and invested in IT, and we set up bed management systems and A&E monitoring systems in ED. Bed, and so we were no longer walking around with pieces of paper and knowing, well, we've got 5 beds on ward 12, for example, and by the time you get down to the bed meeting, those beds have been disappeared, and you start from scratch again. We had real-time information and real buy-in from across the hospital with the culture and and our chief exec in the driving seat, ensuring that the executive and the entire hospital, every single specialty, was bought into the fact that this thing is about safety, and that's the business we're in, keeping people safe. Also, in terms of changing what happens in the organization and not just working in the same old-fashioned way of hoping we survive. Yes, there's lots of work by the medical team. We revised the medical model, looked at the take rota, looked at the systems that would support medical admissions, which is the bulk of your admissions, and opening up a surgical assessment unit. We developed and pioneered streaming, nurse-led streaming at the front door away from the hospital, and also set up an acute medical management team managing the patients out of A&E. Ambulatory care was also linked to the role of ensuring that patients who fit the criteria get into ambulatory care and not stay in the accident and emergency department. Earlier recognition of patients needing an admission, and we grew on this because any senior nurse in an A&E department doesn't need to have a consultant, doesn't need to have a senior doctor involved. Would give you a 95% bet on a patient being admitted. They know from their experience, the observations, the history, and we started requesting beds at the point of triage, at the point of booking in, sometimes by the streaming nurse who's fully aware of the patient's history. And so the bed management team always has an edge. You're always looking for beds for these patients, and to ensure that we're not caught out in the last hour or the last 3 hours, in the 4th hour. Proactive bed management by the patient flow team, and utilizing the services of ExtraMed to ensure that we are fully aware of what's going on in the organization. But probably the most important step change was expanding the organization, expand the integrated discharge team, and the patient flow team and the discharge team, together with the acute teams, work very, very close together. Front door equals back door. The back door is not working. No matter how efficient you are at your front door, in accident and emergency, you are not going to have flow. You are not going to have safety. You're not going to achieve your goals around getting patients out by 4 hours. Integrated discharge team, heavily weighted in moving this organization in the right direction. Key principles. Yes, the board level bought into this, and they made it a priority. Excellent, strong clinical and managerial leadership from medical director, chief exec, every single manager in the trust, every single senior nurse in the trust bought into a whole site approach to ensuring that the front door was safe and the hospital was safe by extension. And as I said before, we managed the back door as aggressively as we managed the front door. Take the noise out of A&E and ensure that those sick patients get the time that doctors need to be with them, rather than rushing around and looking for space all the time, ensuring that there's flow out of ED. Embrace and use technology in the right way to ensure that there's real-time information for us to ensure flow is happening. And utilize, we implemented many robust systems and processes about flows in, out, and alongside of accident and emergency to ensure that we don't overcrowd. Yes, the use of technology, ExtraMed integrated into the hospital system. Symphony as an A&E tracker allows clinical teams to monitor patients' journey from arrival to A&E through to discharge, refer to specialty. Using friendly systems that are utilized across the hospital, also by stakeholders. I mean, we can see on our systems patients waiting for transport. We can see on our systems patients waiting to leave the organization. We can see as much clinical information that we need to make decisions as a patient flow team. It's easy to use at the front door, at the back door. Patients are added on. We all visualize those patients, and we know about the actions that are needed. And easy allocating beds as they are available to patients who need them. We've taken all that away from A&E so that they focus on care, they focus on supporting the very sickest patients and assessing all those patients as early as possible, which is proven to reduce the risk of harm. And yes, the word overcrowding. On ExtraMed, there are multiple team lists. So we can look for our medically fit for discharge. We can look for our patients with detox, delayed transfers of care. We can look at our cardiology patients. We can look at our stroke patients by team, by specialty. And also, we can see who's waiting for transport. We can see who, how we can progress that and get involved in that so it doesn't become a bottleneck at the end of the day. And yes, the wards do use the system to print out their handovers so that they are up to scratch with what's going on with every single patient on the ward. So that basically, in a nutshell, is how we progressed the organization from where we were in 2012 to where we are now in 2018. And final slide. There is no magic bullet. There is no silver bullet. There is no magic solution. There's no one intervention, no cure. The key is culture. The key is leadership. The key is embracing and investing in technology and whole site approach to safety as an important aspect of what we're trying to do. And yes, we failed, and we kept on trying, and we kept on trying. And the culture of this organization is to innovate, to look at new ways of finding things, to listen to people, to constantly aspire to finding better solutions for existing problems. And that's how we turn things around. And yes, every day is a challenge. And just like everybody else, we face the music on a daily basis. But it's a pleasure to come to work at times because we've got a team that understands that safety comes first, and that keeps us going as clinicians. Thank you.
Thank you, Martin. That was very insightful and a detailed journey of how Luton and Dunstable address the A&E performance targets. I will now hand over to Sam Hall, who will be sharing with you how the Derby role addressed their winter pressures.
Thank you, Susan. So I've been asked to share with you a fantastic case study that was created with Derby Hospital about their implementation of our patient flow solution. So a little bit about the hospital. So Royal Derby is a modern state-of-the-art hospital which opened in April 2010, incorporates the Derbyshire Children's Hospital and London Road, which is a community hospital. The hospital provides both acute and community-based services from inpatient, outpatient, surgical, medical specialties, intensive care, maternity services, community, children's, and also A&E. It's one of the largest employers in the area, employing over 8,000 staff across the sites. They deal with approximately 625,000 visits from patients each year, and the split is as detailed across inpatients, emergency, and elective admissions. Many of the beds in the hospital are single rooms, providing privacy of care. They also have 35 hospitals, 4 linear accelerators, 2 MRIs, a Da Vinci surgical robot, and they also have the only rooftop helipad in the East Midlands area. Clinical excellence and compassionate care lie at the heart of the services they provide, and they wanted to enhance on this going forward. An objective the Trust gave us for the project was for an electronic system to replace the many manual processes that were being used to manage the flow of patients through the hospital and beyond. The system would also replace the traditional manual whiteboards that the Trust have throughout their wards and other pertinent locations. Another objective was to ensure that each patient's journey was optimised, inefficiencies in current processes throughout the hospital identified, which would in turn lead to releasing more time to care for safer patient journeys, meaning that the benefits realised from the project were not just of a financial impact or gain. By making the change that would deliver on the objectives, the Trust also believed this would improve the patient's experience during their hospital stay, and also would support the Trust with the compliance of their KPIs, sequins, and their own performance improvement targets that they had set themselves. The specific challenges they identified were their A&E performance was very inconsistent, and the main reason was the lack of visibility of beds once the decision to admit had been made. People were running around wards looking for empty beds to report back to bed meetings, so that A&E would be able to allocate patients into those beds. Consistent issues with managing patient flow from not knowing from any central location what beds were available or about to become available, what activities were needed per patient, who the delayed discharges were, and also the reasons for those delays. With no real-time visibility of bed occupancy, the perception was they always had high bed occupancy, whereas that may not have always been the case in all locations, but just they weren't aware of it. People are also living longer and therefore need more care in their later years when admitted to both A&E and inpatient wards. In addition, 58% of people over 60 have a long-term condition, and an increasing trend shows that for patients over 50, they are more than likely to develop a second or third disease, meaning that the needs become more complex and therefore more time is needed for these patients. As well as the older generation, people with long-term conditions now account for 64% of outpatient appointments and 70% of all inpatient bed stays. So they needed to coordinate and embed a quick installation of the solution. So operational insight and overview was needed for all staff, including the execs. A view of patients needed in real time with accurate, up-to-date bed status. Length of stay was a concern, and that needed to be reduced significantly. The solution needed to be live before the winter pressure period started for the trust, so that they were familiar with the new system and could get to grips with it as soon as possible. So with all of this in place, we had 12 weeks to deploy to wards. It was initially rolled out to all medical wards, cancer wards, and the MAU assessment unit. The success of the installation was so great that the trust immediately started to look at the next areas that they could implement the solution into. So what does the solution provide? It's an intuitive, at-a-glance visual for patients that need specific attention. It delivers visibility of the status of each patient's journey for all staff who have an interest in their patient's care. Colour coding patients nearing their EDD allows them to be highlighted. Delayed discharges are also highlighted in a number of places within the solution. Availability of data on the EDDs has helped the trust clarify their flow issues and put in things to identify and address those. It's easier to identify patients in acute beds who no longer need acute care, so that they can start to manage them out of the hospital. The bed demand and capacity is now visible to all staff across the hospital, and it can be accessed from anywhere so that staff can get to a computer, they'll be able to view and update their patients' information. So the results that were achieved, having the view of patient flow and the availability of beds meant that issues were identified before they happened, interventions were able to be put into place, allowing real-time decisions to be made. Visibility of the patient status and the next actions required meant that the length of stay was reduced across all wards. Delayed transfer of care reduced down to 1.5%, as internal teams could now see what needed to be done for a patient to move them forward in their journey. A&E wait times improved due to the visibility of where patients could be transferred to within the hospital or fast-tracked into the assessment unit because nobody was having to run around and look for data. The ability to deliver on their sequence as they were able to see information in real time. All of the changes meant that more time was released to care for patients, improving their experience. So no more running around to find out the bed demand or chasing paper referrals, because it's now within the system, meant that organisational efficiency has improved significantly. So great was the installation within the hospital that Derby started to look at what else they could do with the solution and how they could improve uses and increase usage of the system. The first thing they looked at was using one of our products called Mobile Medic for running their hospital at night service. It's a smart paging app that allows nurses to raise a call from within the ward that will send an alert to the team so that they can be made aware that a patient on a particular ward needs their attention and also the reason that they are needed for that patient. The business also decided to integrate that further into the business and look at other types of calls that could be raised for lower priority issues. For example, phlebotomy calls, cannula replacement, and things of this nature. They wanted to give teams that weren't part of the hospital access to their patients. So having external teams such as community matrons or oxygen at home team, having a view of their patients that had been referred to them before they left the hospital. So they were able to start putting into place the things they needed for that patient once they'd been discharged. Having dedicated discharge teams, being able to focus on the outstanding tasks, for example, a final blood test or an X-ray or transport to be arranged, meant that those teams could focus on what needed to be done for the patient to move them forward in their journey, rather than having to walk around to each ward just to see who was on the potential list for discharges today. And then finally, allowing GPs to have a view of the patients that part of their practice who were admitted into hospital. GPs have an understanding of the patients who've been admitted on an elective basis, as they are the patients that they've been referred into the hospital by. But having an overview of those emergency admissions mean they can start to step down additional services that that patient might be under. So for example, if they have a matron come in to change dressings, that matron can be stood down if the patient is in the hospital. So it meant they could have a view, communicate back with the trust without having to send emails, faxes, or pick up the phone. They could send information from their GP surgery and receive information back. Derby are a very evolving hospital and are always coming forward with new ideas for how to embed the solution even further into their business. So it's a pleasure working with them. So there's a couple of quotes from the customer about their experience of the installation, which you can read at your leisure. And I will now hand you back over to Susan to complete the presentation.
Thank you, Sam. That was very insightful and a great success, no doubt, for Derby. So just a little bit about ExtraMed, some facts and figures to establish where we actually are now and where we evolved from. So ExtraMed was established in 1999. Currently, we are the market leader in patient flow with a circa of 25% of the market share. Our focus and investment has been on user-centered design and usability, supporting safer patient journeys, digitalizing of current manual processes, thus reducing admin tasks and providing more time to care. Our software solutions run on a wide range of both static and mobile devices, again providing access to real-time information at the right time. ExtraMed, as Sam has actually explained during the Derby white paper, is a solution that goes beyond the hospital walls. Our GP, social care, providing real-time communication without the need for phone calls or faxes. Currently, ExtraMed solution is spread across 14 different sites along the UK, and we've included actually a diagram of these locations for you. Key to our software success is around the integration. We integrate with multiple systems across the whole of the patient journey. The ExtraMed patient solution uses HL7, supporting a single version of the truth and providing real-time information. This allows trusts to select best of breeds for their patient flow, their PAS, EPR, order comms, and many more systems. ExtraMed patient flow manages a patient's complete journey and the experience through the hospital and out into the community. Key to this deployment is our successful way that we actually implement. ExtraMed's deployment methodology represents a best practice framework which we have tailored to meet the needs of each implementation and each individual trust. Our approach is designed to engage with management, clinical and technical staff from the outset. We have 7 stages of our process, which commence with the initiation, followed by our design and build, then the testing, leading on to the training, change management, go live and the support that we provide there, and ultimately at the end, the review and analysing of the deployment and any additional services that we can provide on there. Keeping all in mind, the patient is the centre of our delivery. So during our journey, what actually have we learned about implementing and evolving patient flow? Well, what we have been able to learn and share with our customers is real-time visibility of bed occupancy and patient status at a glance, improving efficiencies, delivering visibility and freeing up time for patient care. Helping staff to make the right decisions at the right time because the right information is available to them. Providing fewer outliers, which leads to improving patient safety and their care. Making EDD visibility available to everybody and allowing proactive steps to be taken for safer discharges. We've also spent a considerable amount of time in terms of change management and ensuring that we involve end users from the beginning of the journey and take them along the journey with us. Partnerships working with staff, making value and benefits clear is key to these deliveries. We view ourselves as partners, not customers and suppliers. Each implementation we tailor to each trust's needs. In summary, we would say there is no need for you to wait for winter pressures to make a decision to digitalise and integrate your patient flow. We're here to help you now. We're here to help you empower your staff by providing a holistic, single shared view of the information they need to improve patient safety and allow them to maximise the time caring for patients and not completing admin tasks. An evolution of your patient flow can be implemented in just 12 weeks. So start digitalising your patient flow in your key departments and involve and extend to digitalising more teams and organisations such as Derby have actually already done so. That will help deliver the full power. We've included here a list of links where you can download further case studies. We'd be delighted to arrange a demo. There's a link actually that will take you to arrange a demonstration. Or if you just have a few questions initially, please don't hesitate to use the email address provided. We'd be more than happy to answer your questions. On behalf of Sam, Martin and myself, thank you for taking the time to listen to our webinar, and please don't forget, we're here to help.